up today, pelvic health goes way beyond just a yearly exam. Coming up, a candid look at the range of treatments for issues that are more common than you may think. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. Some health problems aren't really talked about, as we know, at the dinner table or in some casual conversations. Problems with the bladder, the bowels, or sexual function can be sensitive, but they should not be ignored. And thankfully, there are a lot of treatment options out there. And we're going to talk about them because joining me today is Dr. Kowalik. She is a urologist here at the University of Kansas Health System, and she specializes in female pelvic medicine and reconstructive surgery. Good morning.
Good morning.
She's also my doc too, so glad to see you today here at the desk. And we also have Dr. Kowalik, who has a doctorate in physical therapy and focuses specifically on pelvic health therapy here at the health system, and she is part of a great team of the Pelvic Health Therapy Clinic at the new facility for the health system at our Corbin Park location in South Overland Park. Nice to have you.
Yeah, thank you so much.
Yes, yes. Thank you both for joining us. And before we talk about specific issues, we want to establish that these are sensitive health problems, and we invite all questions today. Nothing's off limits, so get those ready for us. But I have a question for both of you. Do you ever see patients who hesitate to seek treatment, and why might that be?
Yeah, I mean, I think you can imagine it is a sensitive topic, and people don't necessarily realize how common it is. It's not necessarily dinner time conversation with your friends. And so many people suffer for so many years before they come to see me and before they come to see Dr. McCulloch.
And when we say suffer from it, are we just talking about incontinence, or are we talking about other things that have to do with the pelvic floor?
Yeah, there are a whole host of issues that the pelvic floor contribute to. So they contribute to bowel continence and bladder continence. So if you have incontinence of either of those, that is considered a pelvic floor dysfunction. Also prolapse, so pelvic organ prolapse, is another very common condition that women have.
And you do stand corrected, because me and my friends actually have talked about it over at dinner table. So we're just kind of weird like that. But maybe you'll be happy that we're actually talking about it. And then you find, oh, everyone at the table has this issue, maybe as you get creeping towards your 50s and you've had children. But the good thing is, Dr. McCulloch, when people finally come to see you, they are seeking treatment.
Yes.
So tell us what you're hearing when you get somebody in your clinic.
So first off, a lot of people don't fully understand what we do as pelvic health therapists, and we're really take a look at things from a very holistic perspective. That being said, they could be potentially looking into a variety of treatment options that we might be able to offer.
So how common is it? You know, Doc, you said it was common. When we say common, how common?
I mean, it's estimated that about 1 in 3 women suffer from some kind of pelvic floor disorder. And it's also very common in men, not quite as common as it is in women, but there are also lots and lots of men out there with very similar issues.
So how is it affecting men and women differently? And do you see men in the clinic, or is it just mainly women?
I actually see all genders. So I work also with the transgender population, gender fluid, gender diverse, and I would say that a lot of people can actually have very similar issues. It could be bowel and bladder dysfunction, that sexual dysfunction, and pelvic pain issues. And a lot of them can start to feed off of each other a little bit. So not uncommon that they have more than one condition that they're actually seeking treatment for.
So let's just jump right into the show and tell, because you have brought a model. And when we talk about the pelvic floor, kind of show us what we're talking about and all the surrounding areas.
Yes, so this is our female pelvic model, and when we tip it this direction, you can see here all of these muscles in this region. When we kind of talk about the pelvic floor, commonly we're talking about pelvic floor musculature, but it can also include the nerves, blood vessels, soft tissue structures within the region that help to provide continence, provide support to those internal organs.
So explain kind of how the muscles are all connected and how it's all working and how it maybe deteriorates over the time?
Sure. So we actually have 3 different layers of pelvic floor musculature. You've got the superficial, middle, and deep. And you can see they have these nice circular formations in those very superficial muscles. So that's part of the sphincteric control. So being able to hold back urine and feces and then release it when needed. These deeper muscles you can actually see a little bit easier if we separate.
Oh, get in there.
Yes.
Get in there. Show us how this works. Okay.
And it actually creates a bit of a funnel within the pelvis. So these muscles are not just right in here, they actually come all the way up and inside the bones and provide support. So with these superficial muscles, they do that squeeze. With these deeper muscles, they do more of a lift. And that's important for your pelvic floor organ support.
So let's talk about when you have a baby. So how does that affect those muscles? It seems to make sense. You got a big old baby hanging down there, so putting pressure.
Yes.
And in my mind, I'm thinking it's stretching out the muscle. Is that really what's happening?
Yeah, absolutely. Even just being pregnant can place a lot of stress and strain on the pelvic floor, and some women can start to develop pelvic health issues during that time frame. And then once you go through the birthing process, things really have to stretch out and open up to allow the baby to be born. So we know that the nerves themselves can stretch up to 33% of their normal resting state. The muscles go right along with that, and sometimes perineal lacerations or tears of those tissues can occur.
But it could also occur with someone who hasn't given childbirth but maybe has had a C-section, because again, full disclosure, Dr. Kowalik's my doctor. I came to see you frantically saying, I'm ready to kind of fix my problem. And but one of the questions you asked was about, did you give childbirth or have you had a C-section? So how does that vary, and what do you hear from women?
So I want to back up for 1 second. It doesn't only happen in women who have been pregnant as well.
Okay.
There can be a lot of reasons why women develop pelvic floor disorders.
So this is one example.
But this is one example, and it is very common in women who have been pregnant. It is slightly more common in women who have had vaginal delivery, especially if the baby's been over 9 pounds. That will increase the risk of developing urine leakage or bowel leakage. But C-section, you also carried that baby for 9 months against your pelvic floor, you know, and so yes, everything can get kind of weaker and stretched out.
So that seems like maybe an obvious reason why you might have a stretched out pelvic floor. So what are some of those other reasons that you mentioned? So
other reasons can be connective tissue disorders. If somebody has asthma and they're chronically coughing, so chronic coughing, constipation, and the chronic straining can put a lot of stretch on that pelvic floor over years.
That's interesting. Constant coughing, which of course you do feel that down there. Yeah. The cough, the sneeze and pee, as we always say.
Yes.
Those kinds of things happen. I want to talk about what you hear from people. What are some of the different reasons that people come to see you?
I would say, honestly, one of the biggest ones that I tend to see is constipation, even if they don't realize it's an underlying dysfunction. So they might have some bladder issues that they're dealing with, not understanding that that stagnant stool living in their rectum is creating problems for the bladder. That is truly my biggest one.
So let's talk about treatments. And when I came to see you, you went through different types of treatments that we could do. And the one I decided to do was go to see Dr. Kowalik, which I haven't done yet, but I'm going to. And we're going to talk more about how that works in the long term. But generally speaking, how is it treated? Medications, therapy, a combination of both?
Yeah, it can be a combination. And so I think one thing that's kind of great, and I try to explain to patients about the pelvic floor, is that these are skeletal muscles. So they are muscles like your biceps. If you do 30 push-ups every day, your biceps and back muscles are going to get much stronger. They're going to help support your posture. Similar thing with the pelvic floor muscles. If you can do exercises targeted at those muscles, which can be challenging to learn how to do, and that's where Dr. McCulloch comes in. And so pelvic floor physical therapy can help the whole range of pelvic floor disorders. And then sort of depending on which specific disorder you may have, there can be medication, there can be vaginal insert options, and then there are surgical options.
So when we come to you and do therapy, what are we doing? What are you looking for? How are you telling? It is easy to see when you pick up a weight and you see that muscle coming out. Not always easy to see down there. So how do you know that people are doing it right? How do you teach that muscle?
So we really tailor the assessments and treatments for the individual person. So we can use a variety of cueing, mirrors, touch. We also have a rehabilitative ultrasound imaging machine. So if somebody really likes that visual feedback, we can actually show them their musculature on the ultrasound and use it as a biofeedback tool to make sure that they are able to contract sufficiently, relax, and also bear down, which is a very important aspect of pelvic health function. It's great to be able to contract those muscles, but you also need to be able to relax and bear down, or what some people actually call a reverse Kegel.
Okay, and I want to ask you more about the Kegel. How does breathing play a part in all of this?
So your pelvic floor works in concert with your respiratory diaphragm, or it's supposed to. I commonly find that not everybody is actually breathing correctly. So with deep breathing, the abdomen and lower rib cage should expand outward. Your respiratory diaphragm that lives in your rib cage should drop, and your pelvic floor should as well. So it creates this nice sump pump mechanism. And we can also utilize those breathing mechanics not just to get things to relax, to have people develop better body awareness, but also learn to coordinate their breathing and their pelvic floor control with functional activities.
So have the body function the way it was meant to?
Absolutely.
Dr. Kowalik, when is surgery necessary?
Yeah, I think in some cases surgery can be the answer. Usually though, after a trial of pelvic floor physical therapy or other non-surgical options, we really want surgery to kind of be the last step. Because even if you do pelvic floor physical therapy and maybe don't quite get that benefit in your symptoms that you were hoping for, that is still going to help your recovery after surgery.
What about diet? How does diet play a part in our pelvic health?
Well, what goes in must come out. So it definitely plays a huge role in bowel function as well as bladder function. Sometimes people don't realize there are a variety of foods out there that actually could be contributing to some of their symptoms. So we do lots of nutritional education.
What's the best prevention, in your opinion? What's the advice?
Yeah, so best prevention for pelvic floor disorders. Pelvic floor physical therapy, lots and lots of research has shown that getting involved in pelvic floor physical therapy exercises early can actually help slow down the progression of pelvic floor disorders. Maintaining healthy weight, staying active, and avoiding smoking.
Okay, good stuff. What's some of the misconceptions that you hear when it comes to pelvic floor? What are some of the things that what's swirling out there? What are people Googling that you want to clear up?
So I think I have a lot of patients that, they'll show up in my office 10 years after they've been suffering with these symptoms saying, well, I just sort of thought this was a normal part of aging. And while aging is a risk factor for these pelvic floor disorders, it doesn't mean you have to live with them. There are really good treatment options and non-surgical. You don't have to have surgery and still get benefit from the treatments, pelvic floor physical therapy or other non-surgical options.
I know you both are really passionate about this topic. Dr. McCulloch, what I was mentioning how me and my friends, no topic is off limits. We talk about all sorts of weird things. But you must get a lot of questions from people, not just your patients, but people out at the cocktail party asking you all sorts of questions.
Absolutely.
What are some of those questions that you get and people really just inquiring minds want to know?
A lot of it is just about what does it mean? What do we do? And so I'm able to very easily explain to them that we do take a look at you from a holistic perspective, and we're trying to help with your overall pelvic floor function with whatever means we have at our disposal. And some of it does dive deeper into those treatment options, like letting them know we have the ultrasound machine, that we have biofeedback with instrumentation, that we can use a variety of techniques that work best for them.
And what I hear you both saying is there's a layered approach to the treatment. We're going to keep trying until we figure out what's best for each individual patient. Dr. Kowalik, you're a big advocate for the Urology Care Foundation. There's a website that we want to put up, urologyhealth.org. What kind of resources can people find here? So
here are curated resources that are made by experts around the country. And so I think it's very accurate. It's maintained up in real time, so we are constantly updating the pamphlets, but you can find patient brochures, some fact sheets. There are a lot of podcasts to listen to. And it covers the whole range of urologic topics, but there's a whole specific section just on bladder and pelvic health.
Good stuff. All right, so if you have questions, be sure to get those in. You can use the chat on YouTube, Facebook. You can tweet us or email the Medical News Network. Info is right there on your screen. So we got some great questions about Alzheimer's disease during Wednesday's episode of Open Mics with Dr. Stites. Dr. Stites spoke with Dr. Jeff Burns about the newly approved drug that can slow the progression of Alzheimer's disease. And we are bringing Dr. Burns back. We just didn't have enough time for him. We want him, though, to answer some of these questions from our viewers. Dr. Burns, good morning. How are you?
Good morning. Great. Thanks for having me back.
Yes, thanks for coming back. A double take with you because this is a topic that we get a lot of questions on. Sharon wanted to know if there's any drug in development for the treatment of moderate stage Alzheimer's disease.
Yeah, that's a great question, and the answer is yes. There's a lot of focus on treating people in the later stages of Alzheimer's disease, but the most focus is on the early stages and prevention. That's where we're going to ultimately have the biggest impact. So I think the most development is in that area, but there's still development in terms of treating people in the sort of middle stages and later stages. And actually, if Sharon's interested in pursuing research, there's a lot of studies going on around the country, a lot of studies here at KU where we're doing research on moderate stage Alzheimer's disease and trying to understand diagnostics. And then we have occasional studies. We actually don't have one right now for the moderate stages, but occasionally we have a study, looking at drugs in that stage. So that's a longer answer. So not as much in moderate stage Alzheimer's disease, but there's still a lot of work going on in that area.
Let's talk about screening. We've got a couple of questions. The first one from Corey. He says, Alzheimer's runs in my family. He doesn't have any symptoms, but he certainly doesn't want to wait until he shows symptoms to get evaluated. So what kind of tests or scans could he get now?
Yeah, so this is a really common question when people are worried about their risk and thinking, can I get ahead of this? And really the answer right now is there's really nothing he needs to do if he's not having any issues. And so it's a question about screening. Should we be doing sort of population-wide screens looking for people at risk and then going after them? And the answer is not yet. And the reason is we just don't have treatments yet that are proven to stop or slow or really help somebody in that situation. Now, we're working hard on it in terms of drugs. The one advice we give to people like this is exercise, eat right, take care of your heart. What's good for your heart, we think, is good for your brain. So do those common sense things, and then keep your eye on the research, because the day is coming when we're going to be able to spot those changes early or identify people at high risk for Alzheimer's disease and then really go after it to prevent it. That's really what the future, I think, is going to bring. Yeah, that's music to the ears for a lot of people, including people who are looking after their parents. And here is a question that we do get a lot. This person says that they think their dad is showing symptoms. So what tests should he get? Couple things, and are they covered by insurance, and are they easy to get upon request? Right. Yeah. So this is different from the last question. This is somebody who has symptoms, has memory issues that are emerging or clearly present, and it's instead of sort of the prevention idea and the screening idea. Here we're talking about we have issues, we have problems, and yes, they should talk to their doctor, and it would be covered by insurance. What does a doctor do in that situation? You can do some memory testing, a brain scan to rule out common causes of issues that can cause memory issues, and then maybe some lab work. Low B12, low thyroid, those things can influence memory and thinking. Depression, sleep apnea, those kinds of things can influence memory and thinking, and that's what a doctor will think through when they're talking to somebody who has some early changes in memory. And after thinking about those things, then we need to think about this new drug that we talked about the other day, and the other medications that we've been using for 20 to 30 years. So, Dr. Burns, Rosie asked, how many years before you start showing symptoms of plaque buildup before it can be seen in the brain? Is this something that you can scan for in your 30s and 40s? Kind of give us a timeline. Yeah, so the answer is we can see those amyloid plaque changes 10 to 20 years before the onset of symptoms. And so Yeah, so back to the question of screening. Should we screen people for this now? And the answer is not yet, as I mentioned, but we can see these changes early. And that's what gives us hope that we're going to be able to, see these changes, identify them, and then do something to fight them. And we're studying that right now. We don't have evidence that, we actually don't even know how, we know amyloid is linked with the Alzheimer's process, but is it the single cause? The answer is it doesn't appear to be. Removing it doesn't cure the disease, but these new drugs do slow down the disease. So it's more than amyloid. And some people have amyloid in their brain for those 10, 20, 30 years and never develop memory problems. So we have a ways to go to understand what that means. But the answer is yes, we can spot changes linked with Alzheimer's 10, 20 years before the onset of symptoms. And we're beginning to learn how to act upon that information to try to reduce somebody's risk and ultimately prevent the disease.
So on the topic of prevention, Alzheimer's and keeping the brain healthy, there's a website that you're involved in called leapbrainpower.com. Tell us about that. And also, I believe there's a free boot camp that's coming up soon.
Yeah, so thank you for asking about this. There's my picture. We've started this program called LEAP. It stands for Lifestyle Empowerment for Alzheimer's Prevention. 6 or 7 years ago, to answer that question, what should I be doing to reduce my risk? And this is basically a program that takes everything we believe, we're still proving some of it, but everything we believe about our lifestyle. So that's exercise, diet, good sleep, stress reduction, those types of things. And we really try to package it up, we put it in a book, and then we deliver it in various ways, including our boot camp. So it's our answer to that question: what should I be doing to reduce my risk? And we're working hard to get that information out and really try to teach people, what can they do, what power do they have over the risk factors for Alzheimer's disease that we hope and believe will translate into a lower risk of Alzheimer's in somebody's future.
And Dr. Burns, last question. I heard Dr. Stites was messing around with you about your messy office. Is this true?
He was, and yeah, I'm sorry. He said don't change it, but I could put the fake background up. But
no, it's like full disclosure. This is the office of a researcher. You don't have time to clean. I like it. It's like kind of behind.
I know where everything is.
Exactly. And Dr. Kowalik said you have a beautiful mind. This is like the beautiful mind story of just where everything is, and we love it. So we love you coming on and sharing more information about this topic. So many people have questions, so keep coming back, please.
All right, thank you.
All right, thanks. All right, let's get to our COVID count. Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control. And my friend, let me tell you, I have seen the inside of your office. Not much better.
No, it's like a paper bomb went off.
It is.
Very disorganized. I don't know where things are like Dr. Burns does,
Right.
though. He's a lot smarter than me in that. So, but yeah, right now for the COVID count, again, our counts have been really low. That's really good for everybody. Right now, 8 total, 3 active, but 1 of those in the ICU and on the ventilator.
Okay, so Hawk, earlier this week, the World Health Organization updated its advice and analysis on bird flu. You have told us in the past that this is mostly an agricultural, a veterinary issue, but the WHO headline says, quote, outbreaks in animals pose risks to humans. So what is the risk? What are they talking about, referring to?
Yeah, so most of this, again, is avian influenza, highly pathogenic avian influenza. What we have seen with very few cases globally since 2021, only 8 of those. But what we have seen is those people have been in close contact with birds or bird flocks, i.e. mostly working closely with them. We do understand that it is very difficult, and we haven't seen any human-to-human cases, but it's really about those people who are working in and around those bird flocks to really understand, identify, number one, if they have an outbreak within those flocks, and then from there, obviously take precautions. I don't know the precautions that are taken in those commercial, or even if somebody has those on their farm, such as chicken coops. We know that Kansas and around here in Missouri too, there is a lot of rural areas, and we know that a lot of people do have those birds as well. It's very important to understand, monitor your flocks, looking for illness or deaths. don't go around it. Contact your state health department to understand what are the next steps to take. Luckily, again, really no human-to-human transmission, but we need to keep monitoring for that as well.
Doc Hawk, thanks so much. All right, let's get to, well, do we have any reporters with us today? All right, we've got some good community questions, so let's get to those if we can. Bonnie wants to know, and just let us know all the details that we need to know. How does this affect sexual health?
So the pelvic floor is actually very important for your sexual function. It helps to bring blood flow into the area, can create erections in both male and female genitalia. And we can have some pain with sexual activity for some people. And something to know is that's not normal. And if people are dealing with pain with sexual function, we need to find the cause of that and help to treat it to eliminate it.
So we talked about Kegels. So when we hear Kegels, people talking about sitting there doing them. Is that the same thing as pelvic floor exercises?
So yes and no. So pelvic floor exercises absolutely can be Kegels. However, like I mentioned earlier, being able to bear down or do a reverse Kegel could potentially be someone's exercise.
Okay, what is bear down? Explain that again.
So utilizing your intra-abdominal pressure and being able to relax your pelvic floor sufficiently in order to push out babies or bowel movements.
Okay.
So the pelvic floor drops and opens. So that's bearing down. If you think of a Kegel, like I mentioned earlier, the muscles tighten and lift. A reverse Kegel is the opposite. It drops and opens.
Oh, a real exercise.
Yeah.
Okay. Lynn says she can urinate normally, but can also force my urine out faster by flexing or squeezing. Am I doing damage when I do that?
I would strongly recommend not forcing your urination. Urination should be an act of relaxation. Your pelvic floor should be fully relaxed when you are urinating, and the bladder muscles should be doing the contracting. For some people, they might experience some dribbling after they feel like they're done. Maybe there's a little urine left in the urethra itself, and then you might be able to do some just really rapid pelvic floor contractions to essentially milk the urethra from the inside out in that layer that lives in the muscle.
Okay, so like if you're going to the bathroom, you stand up, you still need to go, then you can sit down and kind of do like but nothing like force, like a hard force.
I definitely don't want people straining or excessively pushing with their bladder. They really should just sit down, relax.
Let nature happen.
Yes.
And I think the key here is sitting on the toilet. I think a lot of us out in public restrooms, you want to hover, you don't really want to sit on the seat, but that is really bad for your pelvic floor muscles long term. And so whatever you need to do, keep that seat nice and clean, carry some wipes with you, but sit on the toilet, because that's the only way your pelvic floor muscles are going to relax so that you can completely empty your bladder.
Okay, that's good advice.
Absolutely.
So on that note, I don't know if you've heard of the squatty potty. It was like the #1 sold product on Shark Tank, and I walked into a friend's house the other day, and there was the squatty potty, and it's like a little bench that you put your feet up on. Does that really work? I've heard this is good, and what's it doing?
Yes, so it absolutely can work for the right individual. Say somebody has, just undergone a hip replacement or a knee replacement. Clearly, they're going to have some range of motion deficits and pain, and we need you to be comfortable on the toilet, so maybe not then. However, when you get into that deep squat position, it helps to open up the rectum and the anus a lot better for bowel movements, and it relaxes the pelvic floor more completely. So you're at a better anatomical advantage in that deep squat position.
So you're elevating your knees. So your knees are coming up versus sitting down.
Yes.
Whereas basically back in the old days, you really did have to squat.
Yeah, absolutely.
So this is forcing you to do the true squat that's allowing nature to take its course. So Carrie says, how long does pelvic therapy last? Is this a year commitment? Is this lifelong?
So being in the clinic with us can be absolutely patient dependent. Some people get through things very quickly, maybe in 4 to 6 visits. Other people might actually need to be with us a little bit longer. It might be several months. And like Dr. Kowalik mentioned earlier, just like any other muscle group in your body, you want to make sure that you maintain your gains that you made in physical therapy. So once you leave us, all of the things that you learn do not go out the window. You want to keep maintaining those practices so that your pelvic floor stays healthy.
You're like a personal trainer of the pelvic floor, and then you send us out into the world, and we got to do it on our own. How important is it that we have this as a therapy option, Dr. Kowalik, for your patients?
Their group is invaluable to my patients and the conditions that I treat. I mean, so many people get so much better just by simply doing some pelvic floor physical therapy. Although I do always have to remind them to make sure it is something that you have to sustain on your own at time, because again, if you stop doing those crunches with your arms or with your pelvic floor, the muscles are going to get weak again.
Last question from Alice, and it's a good question because it has to do with Parkinson's, which we were just talking about. Does pelvic therapy help when the root cause of a problem is in the brain? Is there any relation to the deterioration of muscles, and would that be one of them?
Yeah, we can actually still do a lot for patients with those types of conditions. So there could be things that in their daily lifestyle that they might not realize could also be contributing to some of their symptoms, and we can help them to identify those things and then work on it.
So I want to get our takeaways. If there was one big takeaway you want folks to have from this conversation today, Dr. McCulloch, what would it be?
Really, you're not alone, and we are here to help.
And I'm calling you, by the way.
Great.
I have been prescribed to come see you, and so I've got to pick up the phone and call you, and I will. We'll work together. So, Dr. Kowalik, what do you want the takeaway for people out there listening to be today?
When your doctor suggests pelvic floor physical therapy, you should strongly consider it.
Okay.
I know it's not for everybody, but it really, really, really can be so helpful long term in prevention of the issue getting worse, and in treatment so your symptoms are better and you can live the life that you want to live.
All right, thank you for calling me out. I'm going to call her, and then we're going to check back, and I want you to say, see, I told you so. I told you to go see her. So, ladies, thank you so much. Just a really important conversation, like you said, that can really affect all of us, or at least someone you know. So thank you so much. Thanks to all of our viewers for being here with us today. We'll see you back here Monday at 8. Coming up Monday on the Morning Medical Update, Billy Brimblecom Jr. had to lose a leg in order to save his life. Now the cancer survivor is helping others facing the same journey. I'm Jessica Lovell. On the next Morning Medical Update, we reunite Billy with the doctor who saved his life and explore a new exhibition on the past, present, and future of prosthesis. Monday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.